Good afternoon, everyone, and welcome to today's webinar. Before that, I'd like to give a chance to our president to give a few remarks before we kick off. Karibu Daktari.
Yeah, thank you very much, Peter. Want to welcome everyone to this webinar, COVID-related webinars, a joint effort between many organizations, different cadres. Today we want to thank Itrono and Itrono Kirui of Longita County Referral Hospital and for accepting to take us through enhanced surveillance for COVID-19, and we look forward to important learning lessons.
Over to you, Mutai.
Good afternoon, everybody. My name is David Mutai, Senior Nursing Officer working at Bomet County under the umbrella of NNAK Bomet County. We want to take this opportunity to welcome each and every one of you for this webinar presentation, whereby we are discussing on enhanced surveillance for COVID-19. And for today, we are glad to inform you that Kiprona Kirui, a senior nursing officer who is working at Longisa County Referral Hospital, and who is also the chair, Kenya National Union of Nurses for Bomet County, is going to take us throughout this presentation. I want to thank the partners specifically for sponsoring this presentation. And as Kiprono continues with his presentation, I would like to encourage the participants, in case you have any question, kindly inbox so that at the end of the presentation, Kiprona Kirui will be in a position maybe to answer some of the questions you have inboxed us. So let me just say, you are all welcome for this presentation. Kiprona Kirui, karibu.
All right, so welcome everyone for this presentation. My name has been said, I'm Kiprona Kirui, a nursing officer working in Longisa County Referral Hospital. I'm glad that we are in this meeting today to discuss the surveillance for COVID-19. We've been through this since March 2020, when we recorded the cases of COVID-19 here in Kenya, and there's been a great progress in terms of control and management of this COVID-19, and we are glad that we've been able to overcome this pandemic as a country. We thank the partners, the Ministry of Health, We also thank the KMA, the KMBDU, NNAK, the CPAK for what they have done in terms of these continuous online webinars, and we've been able to share a lot of information in regards to handling of COVID-19 cases. So straight away, I'm going to project my slides. We can go through, and then you can write the questions in the chat box so that we can respond at the end of this presentation. Welcome. So, as we are all aware, the whole world has been battling with this COVID-19. We also appreciate the development of the vaccines that were rolled out, and that has become as a stopgap measure in terms of fighting this pandemic. So as you can see, coronavirus is a disease that affects the respiratory system. And by definition, we could say it's an acute respiratory infection that is caused by coronavirus type 2. And this belongs to a family of subcovirus subgenus of Coronaviridae family. And this is the 7th coronavirus that has been known to infect humans. WHO declared COVID-19 to be a pandemic or a public health emergency in 30th January 2020. And it became as a threat to the whole world. Everybody was wondering how will we handle this. So WHO declared as a concern in 30th January 2020, and subsequently in 11th March 2020, COVID-19 was declared as a pandemic. The pace at which COVID-19 spread throughout the world and in Kenya was unprecedented. It was unexpected because it was moving so fast. Kenya discovered the first documented case of COVID-19 in 13th March 2020. And from the statistics that you can see in this slide, in the 18th of July 2021, the total number of cases was reported to be 192,758, with about 3,775 people dying from this outbreak. From the data in the DHIS currently, the number of total reported cases is 342,703. And the deaths which Kenya has recorded so far is 5,668 from this pandemic. So I think the first thing that we start with is we want to understand this case definition of COVID-19. So in terms of COVID-19, we have suspected case, we have probable case, and we have a confirmed case. So we will start by defining what we mean by suspected case of SARS-CoV-19. So the first case definition will be the person who meets the clinical and epidemiological criteria. So that is the first definition that we want to appreciate in defining a suspected case. The individual must meet a clinical and epidemiologic criteria. So in terms of clinical criteria, a client will present with an acute onset of cough and fever, or the patient has an acute onset of any of the two or more of the following signs and symptoms. So the patient may have cough, fever, loss of taste or smell, difficulty in breathing, sore throat, runny nose, chest pain, fatigue, headache, diarrhea, and altered mental status. And this is this is where the children usually present with. They have an altered mental status. So anyone who meets any of those criteria will place him under suspected case of COVID-19. Then we have epidemiological criteria. If a person is residing or working or travel within the last 14 days to an area with high risk of transmission of the virus. In Kenya, it will be reported by the Ministry of Health. Or in a case whereby there is widespread community transmission in several regions of the country, then all patients will be considered to have met epidemiological criteria. So in this, in terms of epidemiological criteria, we are seeing people coming from that geographical area where there has been declared an outbreak of COVID-19. In such a case, we'll say the patient has met to be a suspect under epidemiological criteria. Or if the patient is working in a healthcare facility or has had an international travel, for example, from a country reporting COVID-19 in the last 14 days. Another criteria that we use is if a patient has severe acute respiratory illness. If a patient, for example, presents to a casualty department with, a severe acute respiratory illness, then such a case will fall under a suspected case. And the patient may have, they have this severe acute respiratory infection maybe without any fever, or they may have cough, and this onset was within the last 10 days. And for such a patient who will require what? Hospitalization. So we'll say this is a suspected case of COVID-19. Then we move to probable case of COVID-19. So the person who meets the clinical criteria as we discussed earlier and has been in contact with a confirmed case or an area that is linked to COVID-19 cluster, we will say this is a probable case of COVID-19. A suspected case with chest imaging showing findings suggestive of COVID-19. We all know that X-rays can be done, and if these X-rays are suggestive, if they are suggestive of you see COVID-19, and the patient had has met the clinical criteria, we will say this one is a probable case. Or if the patient presents with a recent loss of taste, which was of sudden onset, loss of taste or smell, with no other causes which has been identified, then we will say this is a probable case of COVID-19. Sometimes imaging can be done, and it may show opacities within the lungs, and this may suggest COVID-19. Or in cases whereby we have an explained death in an adult who has severe acute respiratory infection and had contact or confirmed case or linked to COVID-19 cluster, then we will say this is a probable case of SARS-CoV-19. Then we move to the third one, which is confirmed case of COVID infection. So a person who tests positive through PCR, then that one is definitely a positive case. Then a person with antigen test, if the antigen test also is positive and meeting criteria for either suspected or probable case, this will be a confirmed case. Or if has contact with a probable or confirmed case. Then after classifying into a suspected case, probable case, and confirmed case, now we want to shift gears to infection prevention so that we can be able to control the spread to the other people who are around the patient, the general public. So here, infection prevention is very key. It is very key in terms of cutting the spread of this COVID-19. So the main aim of infection prevention is to prevent or limit the spread of COVID-19 at all levels of healthcare. So we are expecting that all facilities should have, on the minimum, these kind of programs, such as, an infection prevention control program or a dedicated focal person. When in any facility, whenever we have a focal person for such a program, then we will be able to, handle a number of things. Then we also need a functional screening and triage area for early case identification. And also a holding area for cases awaiting results or transfer. So after triaging, then we need a holding area and a mechanism to ensure that, standard transmission-based precautions and adequate healthcare workers to provide 24-hour patient care without exhaustion. You know, here in Kenya, we have challenges with staffing. You move to any other government facility, they talk of staffing. And that was also a challenge. And that is why we thank the government of Kenya through the Thought of UIC program that were able to be posted to assist in mitigating COVID-19. We also thank governments such as, for example, the government of Bomet, which was also able to employ people, to employ all cadres to help in, working in these COVID-19 centers, and we were able to, fight this pandemic. I plan to conduct health worker exposure risk assessment, which we've done, and continuous training and refresher courses, such as this one that we are doing online, and the one that we've been able to do in person. Then we also need adequate infection prevention control, supplies, and equipment. So as you can see from this table, these are typical layout of an isolation unit. So it has several areas whereby we have, the staff entry, and on the other end is the patient entry. Then we have that waiting room and triage. So the staff who is on the waiting room and triage will triage every patient to either whether they are going to a symptomatic area, to the mild, moderate, the severe, or the critical. And in case of eventuality of death, then we have, the mortuary there. So that is a typical layout of an isolation unit. So in terms of also infection prevention, we need to provide personal protective equipment. But you see, because these things also are expensive, we need to provide according to the level of protection that we want to achieve. So this has been categorized into level 1, level 2, and level 3. Under level 1, we need equipment such as disposable surgical mask, facility uniform, and gloves. And this one is usually applied in the triage area, in the outpatient clinics, and in the private clinics. Then in terms of level 2, we may need uniform, N95 mask, caps, waterproof surgical gowns, gloves, eye protection, and plastic apron. And the scope that this is used is in COVID-19 clinics, in isolation wards and critical care units, radiology units for confirmed COVID-19 patients, and in decontamination and cleaning, especially by the public health officers, and laboratory, and our farewell home. Under level 3 protection, we also need scrubs, N95 mask, a waterproof surgical gown, because you may want to do intubation and there will be secretions. So you want something that is waterproof, that can be able to protect you from coming into contact with the secretion from the patient. So face shield and Google in case of any vapors. Then there is caps and gloves. So this one is applied usually during sanctioning of the patient, during intubation, or when performing procedures such as bronchoscopy or endoscopy, colonoscopy, and during surgeries. So these are guidelines that were given as key IPC measures when handling a suspected or confirmed COVID-19 cases during screening and triage. So when you have suspected that the patient, or you confirm that the patient is having COVID-19, you need to provide that patient with a medical mask. And you direct the patient to separate a bit from the patient, or to an isolation room if it's available in your facility. You also want to maintain a distance of 1 meter, 1 meter distance between patients. And you also want to ensure that areas are well ventilated with good airflow. So you also want to instruct all patients to cover nose and mouth with tissue or flexed elbow during coughing and sneezing, and perform hand hygiene after contact with patient or patient or environments. And this is very key. This is very key in terms of eliminating COVID-19 and most of the respiratory infections. There should also be signage and posters and audios and televisions that are advising patients and relatives on signs and symptoms of COVID-19 and, these infection prevention measures. This is obvious this could look like obvious to the healthcare workers, but it may not be obvious to the patients and the caretakers. So they may need these audios and TVs to show them, how to handle a COVID-19 case at home. And parents and caregivers also need support, because you see the children may not be able to follow all these guidelines in terms of, mitigating the spread. So in case the patient, they should provide a tissue, for example, to a child to cough into. And parents also need to guide their children on hand washing, the use of soap and water. So I also ensure that there's a rational use of PPE in order to avoid wastage, because we all know that these things are expensive. It's expensive to the country, expensive to the county. We want to use it, for that specific purpose, so that we don't waste the PPE. So we move to diagnosis of COVID-19. Testing is only recommended for diagnosis and not as an indicator of recovery from COVID-19. And testing should be over to all persons, meeting the case definition as we had earlier discussed, in terms of suspected, probable, or confirmed. So we test according to whether the patient is meeting those cases, so that we don't test every other person. So the initial test, or the gold standard test, will be the PCR test. So the PCR test will be the gold standard in identifying this patient. But in areas where we are not able to do the PCR test, then we can do the antigen test. Can utilize the antigen test. Although the antigen test, the turnaround times for antigen test are generally shorter than for the PCR testing. And thus, an antigen test can help with quick identification of COVID-19 cases. But you see, sensitivity of antigen test is lower when we compare to the PCR. So a negative test of antigen, and the patient is symptomatic, then you will need to move ahead and do a PCR test for that patient who is symptomatic. Whenever you are using an antigen test and it turns out to be positive, then that one you count it as positive. You count that one as positive, and you don't need to do any further, investigation. So from these charts, we can see, or we can appreciate the antigen testing algorithm. So we will have two types of patients: a patient who is having symptoms and a patient who doesn't have symptoms. So for a patient who is asymptomatic or who doesn't have symptoms, you're using an antigen test, they can either turn to be antigen negative or antigen positive. So in a situation whereby the patient will be antigen negative and there is no known exposure, you don't need to quarantine this patient. Just allow the patient to go home. But in the event that the antigen test turns out to be positive, then it indicates there is an infection. So you will need to isolate. You need to isolate this patient. Now, for a patient who is symptomatic, now he has cough, fever, sore throat, and you do the antigen test, and it turns out to be negative. Then what you need to do, that one is confirmed negative. And what do? You ask the patient whether there is exposure. If there is no exposure to COVID-19, you don't need to quarantine. But if the patient is in close contact or a suspected case and there is exposure, you quarantine that patient for a specified period of time. Now, in the event that the antigen test positive, that one indicates that there is infection. So what do you need to do? You isolate the patient. So the specimen that we usually rely for testing, we usually collect from the upper respiratory system, and in some cases in the lower respiratory tract. Especially the laboratory officers have been of great help to us in collecting this kind of specimen and testing the clients. So upper respiratory tract samples include the nasopharyngeal swabs, the oropharyngeal swabs, and the nasopharyngeal aspirates. This one we use to make a diagnosis of whether the patient is negative or positive. Lower respiratory tract specimens include bronchoalveolar, lavage specimens, and expectorated sputum. Now, we ask ourselves, what is the role of radiological tests for the diagnosis of COVID-19? Are they conclusive? Are they not conclusive? Yes, as we indicated earlier, we cannot rely only on the radiological test, but the CT scan, for example, can help us to monitor and see how the patient is responding, or to check on the progress of the patient. Now we move to, now you've recognized that the patient is confirmed positive, so what do you do? So the management of patients with COVID-19, it depends on severity of the disease at presentation. Once you confirm that the patient is positive by a PCR or a rapid antigen test, you need to categorize them into 4 groups. So first of all, before you treat the patient, you need to categorize, because a different group or a different category will need different intervention. So as we can see from this table, the COVID-19 severity categorization in adults and adolescents. So there are 4 categories there, as you can see in this chart. We have mild illness, we have moderate illness, we have severe illness, and critical illness. So for a patient to be categorized as having mild illness, the patient will have these features, which are projected on my right side, which is fever, cough, sore throat, malaise, headache, muscle pain, but the patient doesn't have dyspnea and no abnormalities on the chest imaging. So for such a case, although the patient is positive, you will categorize them under mild illness. We say a patient is having moderate illness if they have clinical features of pneumonia, that is fever, cough, and dyspnea. In such a case, you will say this patient is having moderate illness. And or radiological features of pneumonia, but oxygen saturation is greater than or equal to 94% on room air. So if the patient SpO2 is greater than 94, although the radiological features are showing pneumonia, then that patient will be under moderate illness. Then for severe illnesses, clinical and radiological features of pneumonia, and the patient is tachypneic. We all appreciate that, so although the different books talks of different rates, the normal respiratory rate is 12 to 20. But you see the patient there is having tachypnea of 30 breaths per minute. So more than that, you will classify them as severe illness. And the oxygen saturation usually is less than 94% on room air. Then, as we can see, the last category is critical illness, and it will be features of severe illness and any of the following. That is, the patient will have respiratory failure, sepsis, septic shock, multi-organ dysfunction, and acute thrombosis. So in such a case, you do the test, you see the patient through clinical examination that the patient is having septic shock, multi-organ dysfunction, and thrombosis. Such a case you classify under critical illness. So colleagues, it is very important that we classify these patients who are positive into these 4 categories so that we can be able to intervene appropriately. So now, if a patient has mild illness, then the next thing to do is you want to assess them for eligibility for home-based care. So if there are no risks for disease progression, that as you have assessed, you assess home, there is availability of a separate room, separate bathroom, and there are resources for PPE, and the family members are also, able to handle this, then the patient is discharged home. There are some risk factors that will make you not to, allow the patient to go home. especially who has mild illness, and there are risk factors. And these risk factors may, predispose the patient to progress to severe illness. And these risk factors include the person who is 60 years and above, the person who has pre-existing conditions such as coronary artery disease, the person having stroke, diabetes, hypertension, cancer, chronic lung disease, pregnancy, and immunosuppression. They have risk factors. Now, if a patient has mild illness, you just manage symptoms by using drugs such as paracetamol and antihistamines such as chlorpheniramine. NB, steroids should not be used for patients with asymptomatic, mild, or moderate disease. So we avoid steroids in such a case. Now, you categorize your patient as having moderate illness. So what do you need to do? You want to carry out baseline tests. So you do further investigation. You want to check the complete blood count. You want to see what is happening with the different cells of the blood. You also want to do check on the renal failure, that is UECs, urea creatinine, the liver function, and the HIV test, and random blood sugar. So symptomatic treatment. We have for a patient who has moderate illness, you want to give paracetamol. If the patient has sore throat, you want to give gargles. The patient has cough and nasal congestion, you have to give antihistamine. So essentially, for a patient who has moderate illness, you want to manage, the symptoms. It's also important to note that we need to give a venous thromboembolism prophylaxis. So because you don't want to wait the patient to develop thrombosis so that we can intervene. So at this level, we want to keep prophylaxis. And we're using enoxaparin 40 mg once a day if the patient is admitted in a health facility. Now, because we all know that this enoxaparin that sometimes might be expensive for some patients, and if it is unavailable, you may want to use heparin, and fractionated heparin, that is 5,000 units, subcutaneous, 2 times a day or every 12 hours. Maybe in cases whereby we have challenges with the nursing infrastructure, some patients with moderate illness can be managed at home, because you see, we cannot have every other person within the hospital because of challenges of space. So these are some of the people who can go home. If the patient is young and saturating at 94% on room air, if they have no comorbidity such as hypertension, coronary artery disease, such as diabetes, then you can just allow these patients home. Or if they have easy access to health facility in case of worsening symptoms. And if the patient also is physically active, you can comfortably discharge that patient home, but with monitoring and follow-up. Now, in a situation whereby we have severe illness, when the patient is having severe illness, you want to carry out some of the baseline tests, such as complete blood count, renal and liver function tests, the HIV test, and the random blood sugar. And you treat symptomatically, that is by oxygen supplementation, and you want to achieve oxygen saturation of above 90%. But if the client is pregnant, you want to go to a target of 92% so that you don't compromise on the baby. So one thing that is also worth noting is that for a patient who with severe illness, you now want to use corticosteroids such as dexamethasone, 6 milligrams per day for up to 10 days. But if you cannot access dexamethasone in your facility, then you can use prednisolone or Prednisolone. And we all know that whenever you're using prednisolone, we usually taper. But in these cases, because we are using for a short period of time, there is no need for tapering the dosages of prednisolone. For children, then the dosage of dexamethasone will be 0.15 mg per kg per oral once a day to a maximum of 6 mg, or prednisolone 1 mg, OD, maximum 40 mg OD. We also want to, give venous thromboembolism prophylaxis with an enoxaparin 40 mg. If you don't have an enoxaparin, that is Clexane, then you use, unfractionated heparin 5,000 units. Then we also need to do what we call self-proning. If the patient can tolerate self-proning, because it has been shown that when you do self-proning, it improves on the, expansion of the lung. And, so as the patient tolerates, you want to use self-proning for 12 to 16 hours. Now, in a patient that is category 4, critical illness, what do we do? All we need to do is, carry out a baseline test, such as total blood count, renal, that is UECs, creatinine, liver function test, and HIV test, and the random blood sugar. And then the management also, again, will be symptomatic treatment. What do you need to do? You admit this patient to the critical care unit, put on mechanical ventilation if there is no improvement in oxygenation. And you may want to, increase the oxygen flow so that, as much as possible that you ventilate this patient very well. And whereby this tolerated, you need to prone this patient for 12 to 16 hours per day. Also, fluid resuscitation or fluid management is key, because you see, we said such patients may also have septic shock. So we want to give them fluid therapy to alleviate, hypovolemic shock. So closed sanctioning of secretions where available, so that you avoid the spread to, people who are also around. Dexamethasone also is given, as we indicated, for the others. And for children, that is the dosage of dexamethasone, 0.15 milligrams per kg per day. Then you also want to give Clexane 40 mg once a day. If Clexane is not available, again, you use the normal heparin for a period of 10 days. There are other therapies which we use. Other therapies which can be used in management of COVID-19 are as displayed in this slide. So these are some of the drugs which also can be used. Like, for example, we have such a drug which is a monoclonal antibody. It's called tocilizumab, which is a monoclonal antibody against interleukin-6. And hospitalized patients with severe and critical COVID-19 with disease progression and elevated markers. They can. Another drug that can be used is baricitinib, and remdesivir can also be of help in management of our clients. Now, NB, when the COVID-19 hit, every other person was suggesting that this drug is working, this drug is working, this drug is working. But current studies do not seem to support. So the current evidence do not support the use of the following interventions for the treatment or prevention of COVID-19. So it is no longer recommended that you use any of these drugs in management of COVID-19. Like, for example, hydroxychloroquine or chloroquine, azithromycin, ivermectin, plasma therapy, and empirical anticoagulation, aspirin, high-dose steroids, vitamin C and D, zinc, ulinastatin, and favipiravir. So this are no longer recommended because it doesn't treat and it doesn't prevent the COVID-19. Thank you for listening to me. So,
okay. Thank you everyone for listening to this presentation. My name is still Mutai, and thank you, Bruno, for taking us through. I didn't box each and every one of you that in case you have any question, kindly inbox us so that the facilitator for today can be in a position maybe to answer us any question you could be having. So I've just gone through the charts, but I haven't gotten any question raised by any one of you, but still the floor is still open. If in case you have any question, kindly.
Or an addition or a comment you can make, you're welcome to make your comment. All right, thank you. Thank you. There is a question from Duncan Kimweno asking, is intubation really encouraged in confirmed COVID-19 patient with respiratory distress? Yes, according to the guidelines that were released by the Ministry of Health in 2021, around August there, if a patient is having critical illness, you will have to intubate. Then there's a question about, thank you, Bananyole, for listening. Thank you for this question. My question is, how is surveillance currently within our county and particularly Longisa County Referral Hospital? Thank you. Maybe I can allow Mutai to respond to that.
Okay, Mr. Nyole, I know that question of yours specifically is concerning our facilities, Longisa County Referral Hospital. Maybe what I can say right now is we have a special committee in our facility, the Infection Prevention and Control Committee. And I know maybe because you are within our facility, maybe you can get in touch so that maybe we can just brief you on what's actually going on within our facility, specifically in Longisa County Referral Hospital in Bomet County. Thank you, Mr. Nyole.
And again, Mr. Nyole, as at now, we do not have any positive case within Longisa, but Kenya is still recording, cases of COVID-19. So as of today, we do not have any positive case in our facility, but the country is still recording positive cases. Thank you, Mr. Victor Langat. Thank you for your comment. Thanks a lot, Bananyale. All right, so we shall share slides. I have seen someone who is requested for slides. Let me get your mail. We will share the slides. Claire Mukanda, 75@gmail.com. I will share the presentation. We'll send it to you. Thank you. Thank you, Claire.
Before we go back to our host, that's the KMA, Kenya Medical Association, let me just hear something from Peter from KMA. If Peter is having anything before I give up my final remarks as the moderator for today. Peter?
Thank you very much, Kiprono, for the good presentation. Thank you very much, David, for quite a good moderation. For me, I don't have anything else to add. I just want to thank all the attendees for making time to be able to join us this afternoon for this webinar. And I want to wish you a good afternoon, and thank you very much, and see you next week.
Thank you.
Okay, thank you, Peter. let me just say something. I just want to really thank our partners at the KMA, Kenya Medical Association. We also have the KMBDU, National Nurse Association of Kenya, being led by our president, that's Collins from Kisumu. We have also CIBAC. We have the Kenya Clinical Association of Kenya and the PSK, that's the Pharmaceutical Society of Kenya. We want to say a big thank you for each and every partner who has ensured that this presentation has come out successfully. Unless there is no any other question, I want to just say, I want to wish each and every one of us a nice afternoon, and maybe Peter, each and every one of us maybe can leave at our own pleasure as we end this afternoon session. Unless Bruno has.
Thank you.
Thank you.
Thank you very much. See you guys next week.
All right.
All right. Bye-bye.
Bye-bye. Bye-bye, everyone.
Bye.
So